imagine you're sitting in a doctor's office,
Right.
right? And the physician is looking at this calculator on their computer screen.
Right.
And this calculator says that you are at a dangerously high risk for a stroke, which, obviously means you desperately need a strong blood thinner.
Exactly. You need to prevent that clot.
But then right next to it, there's a second calculator.
Yeah.
And that one says you're at a super high risk for a fatal bleed, like if you take that exact same blood thinner.
Yeah.
So what does the doctor actually do?
I mean, it is the ultimate tightrope walk. And it's this exact scenario that's playing out in neurology and cardiology clinics thousands of times a day.
Well, welcome to another deep dive. Today we're cutting straight into that high-stakes architecture of stroke and bleeding risk.
It's really fascinating space.
It is. And our underlying thread today is this concept of, well, what is given? We're looking at the baseline biological hands that patients are given by nature, the mathematical scores they're given by their doctors, and ultimately the precise treatments they are given to sort of rewrite those odds.
And, while medicine can sometimes look a bit like guesswork to an outsider, like we're just throwing darts, there is actually this incredible rigid scaffolding of historical trials and algorithms beneath every single decision.
Doctors aren't just rolling the dice here.
No, not at all. They are navigating decades of hard data.
Right. So before a doctor can even decide what treatment to give, they have to figure out what kind of stroke they're actually dealing with in the first place.
Yes, the mechanism.
Exactly. So we're starting with the TOAST classification, T-O-A-S-T. Think of it as the mechanistic backbone of stroke categorization.
Right, so ischemic strokes, which, just to clarify, are strokes caused by a blockage, they get sorted into 5 specific categories, all based on the underlying plumbing issue, essentially.
Okay, so what's bucket number 1?
The first one is large artery atherosclerosis.
So that's like if you picture a main pipe in your house,
Yeah.
and it's just slowly rusting shut from the inside with plaque until, nothing can get through.
That is a perfect way to visualize it, yeah. Then you have the second category, which is cardioembolism.
Cardio, so the heart.
Exactly. This is less about the pipes themselves and more about the water pump. So a clot forms inside the heart, it breaks loose, and then travels upstream until it wedges into an artery in the brain.
Oh, wow.
Yeah, and we actually split this one into 2 tiers. You have high-risk sources, like if someone has atrial fibrillation or, say, a mechanical heart valve. And then you have medium-risk sources, like a patent Foreman oval, which is often just called a PFO.
Wait, let's pause there for a second. A PFO, what exactly is that?
So a PFO is a small hole between the upper chambers of the heart. We actually all have it before we're born, but in a pretty significant portion of people, it doesn't close all the way after birth.
Wait, really? People just walk around with a hole in their heart?
Yeah, quite a few people do, and usually it's fine. But under certain pressure conditions, it can allow a tiny clot to slip across the heart chambers, bypass the lungs, and travel straight up to the brain.
Wow, okay, so we've got rusted pipes, water pump debris. What's the third bucket?
Third is small vessel occlusion. Technically, this is known as a lacunar infarction.
Okay, let's translate that one, because lacunar infarction sounds incredibly intense.
It does sound traumatic. But so if the large arteries are the major multi-lane highways delivering blood to the brain, these small vessels are like the tiny microscopic side streets.
Okay.
A lacunar stroke happens when one of those tiny side streets gets blocked. It's very small in diameter, but depending on the exact neighborhood of the brain it's in, it can do a massive amount of damage.
Got it. It's about location. And then we have the fourth category, which is simply other determined causes.
Right. Those are your less common issues. Things like rare blood clotting disorders or maybe a physical tear in the artery wall itself, like a dissection.
Which leaves us with the fifth category, strokes of undetermined cause.
Yes, the undetermined group.
Now, I gotta say, looking at this as a patient, that sounds like a giant junk drawer. Like the doctor does all this high-tech MRI imaging, runs all the blood labs, and then just shrugs.
I know, it is so easy to assume it's just a cop-out, but that undetermined label actually represents 3 distinctly different realities for the patient.
Okay, how so?
Well, first, you have the cases where the clinical workup was completely negative. We looked absolutely everywhere and found nothing.
Like a true medical mystery.
Yes, exactly. But the second reality is actually the complete opposite. A stroke is also classified as undetermined if a patient has 2 or more identified potential causes.
Oh, wait. 2 causes?
Yeah. Say someone has terrible atherosclerosis in their neck, right? But they also have atrial fibrillation, We have two smoking guns. We just don't know which one actually fired the bullet this time.
Oh, I see. So it's not a lack of evidence. It's like too much conflicting evidence.
Precisely. And then the third reality is simply an incomplete workup. Maybe the patient was, too unstable to finish the MRI, or the testing was just cut short. So undetermined is actually a really crucial bucket because it tells the doctor exactly what flavor of uncertainty they are managing.
That makes total sense.
Yeah.
So, okay, once you have the stroke categorized, once you know the physical mechanism you were basically given by nature, the immediate next step is figuring out how likely it is to happen again.
Yes, predicting the future.
Right. And this is where patients are given their math, the scores.
Stratification scores, yeah.
Yeah.
So for patients with atrial fibrillation, the foundational tool for a long time was CHADS-2.
CHADS-2.
Exactly. It's an acronym. It assigns 1 point each for congestive heart failure, hypertension, age over 75, and diabetes. And then it gives 2 points for a prior stroke or a transient ischemic attack, which is basically a temporary mini-stroke.
Now, what really stands out to me when looking at how this is applied is how steep the mathematical gradient is here. Like, if a patient scores a 0, their stroke rate is under 2 events per 100 patient years.
Right, very low.
But if they hit a score of 6, that rate just explodes to over 18 events. I mean, every single point is a massive leap in danger.
It is a really steep cliff. But, medical tools are always evolving, so CHADS-2 was eventually updated to a much longer acronym.
Right, CHA2DS2VASIC.
Yes, quite a mouthful.
So here's my question on that. CHADS-2 is elegant, right? It's simple. You can memorize a few letters, count the points on one hand. Why complicate it? Why add more letters and points? Like, what is CHA2DS2VASC actually giving us that the old score couldn't?
It added refinements, things like vascular disease, an intermediate age bracket, so between 65 and 74 in female sex.
Okay, but why?
The reason why is actually this brilliant shift in perspective. The goal wasn't just to make the high-risk patients look riskier.
Because if you're high risk, you're high risk, you're already getting the treatment.
Exactly. The true superpower of the new score was its ability to accurately identify the truly low-risk patients, the true zeros.
Oh, interesting.
Yeah. If CHADS-2 was a bit blunt, it might score someone a 0 who actually had some hidden risks, like early vascular disease. Or, conversely, it might push someone into a treatment category they didn't really need to be in.
That makes total sense. Because blood thinners, the anticoagulants, they are serious medications.
Very serious.
By making the scoring system more granular, doctors can confidently spare those true zeros from being given unnecessary blood thinners. You're building a stronger, more accurate shield for the people who are actually safe, so you don't expose them to harm.
You nailed it.
And that brings us full circle to the very beginning of this deep dive, the core tension we talked about. Because anytime you give a patient an anticoagulant to prevent a clot, you introduce a brand new threat.
You are inducing a bleeding risk. That is the fundamental balancing act in cardiology. And to manage it, we have the mirror image of our stroke calculator.
Right.
It's called HAS-BLED.
HAS-BLED. Quite the visual acronym.
It definitely spells it out clearly. It gives points for things like hypertension, abnormal renal or liver function, a history of stroke, prior bleeding, a labile INR.
Wait, labile INR, what does that mean exactly?
Oh, it just means someone's blood thinner levels are fluctuating uncontrollably in their blood tests.
Okay, got it.
Right, and it also includes age over 65 and drug or alcohol use. The maximum score is a 9, and basically anything above 3 flags a genuinely high bleeding risk.
Okay, so let's put ourselves back at the doctor's desk. The patient has a high stroke score, which is screaming at the doctor to write the prescription. But they also score, say, a 5 on HAS-BLED. What happens? Do they just cancel each other out? Do doctors just look at high stroke risk and a high bleeding risk and, throw their hands up?
This is honestly one of the most common misconceptions in cardiovascular care.
Really?
Yeah. Many people think a high HAS-BLED score is a stop sign. They assume if the bleeding risk is high, you absolutely must withhold the blood thinner, but that's a dangerous trap.
But why? If the patient is super likely to bleed, shouldn't you hold off?
Because the stroke risk doesn't magically go away.
Oh, okay.
In fact, they often track together. If you withhold the drug, that patient is left incredibly vulnerable to a catastrophic clot. So instead of a stop sign, the HAS-BLED score should actually be viewed as a map.
A map to what?
It highlights modifiable bleeding risks.
Modifiable, meaning like things on the list you can actually fix right now.
Correct. You cannot change a patient's age, obviously. You can't erase their prior stroke history. But if their HAS-BLD score is sky high because their blood pressure is completely uncontrolled, or maybe they are consuming heavy amounts of alcohol.
Then you target those.
Exactly. The clinical value is identifying those factors and aggressively addressing them alongside starting the anticoagulation. You don't abandon the treatment, you tighten up the environment so you can give the drug safely.
That is such a crucial distinction. So if fixing blood pressure is the key to lowering that bleeding risk and safely preventing strokes, like how much does fixing it actually help?
Oh, it's huge.
Because the historical data we have on this is just staggering. Let's dig into the massive clinical trials that proved exactly why these specific treatments are given.
We have to talk about the landscape of hypertension trials. They are foundational. A great example is the PROGRESS trial.
Okay, so how did they actually set that one up?
Well, the researchers took thousands of patients who had already suffered a stroke or a TIA, right? And they gave them a combination of blood pressure medications, perindopril and indapamide.
Okay.
The fascinating outcome was that the stroke risk plummeted regardless of what the patient's baseline blood pressure actually was when they entered the trial.
Wait, really? So even if a patient wasn't classically considered hypertensive by the standard definitions, taking the medication still drove their stroke risk down?
It did. The sheer biological act of lowering the pressure was protective in itself.
Wow.
And then you have the SAP trial, the systolic hypertension in the elderly program. This was crucial because it targeted people over 60 who had isolated systolic hypertension.
Let's define that for a second. That's when only the top number of your blood pressure reading is high. The pressure when the heart is actively squeezing.
Yes, exactly. And historically, some physicians actually thought high systolic pressure was just a natural, unavoidable part of aging. Like, oh, they're just getting older.
Right, the pipes just get stiff.
Exactly. But the SEP trial proved that treating it specifically led to a 36% reduction in stroke over 5 years.
36%. I mean, if you or your parents are taking a daily blood pressure pill, this is exactly why.
It's massive.
And there is a broad summary figure from all this data that is absolutely worth committing to memory. Lowering that top systolic number by just 10 to 12 points and the bottom diastolic number by 5 to 6 points, that translates to a massive 38% reduction in stroke incidence.
It's an incredible return on investment. Just a tiny numerical adjustment in the pressure wipes out nearly 40% of the risk.
But of course, blood pressure is only one lever. The other major lever is cholesterol. Let's talk about statins.
Ah, yes. The statin evidence was built incrementally over many years. It really started with the MRECL trial, which focused on patients with very high-risk coronary disease. Putting them on aggressive cholesterol-lowering therapy showed a 50% relative risk reduction in stroke.
50%, a literal coin flip difference.
Yeah.
But to be fair, that's for people whose hearts were already in serious trouble.
True. So the scientific community understandably asked, does this work for broader populations?
Naturally.
And that led to ASCOT-ELA, which looked at patients with comparatively low coronary risk. And it still found a 27% relative risk reduction for stroke.
Okay, still significant.
Yeah. Then the heart protection study proved the benefit across a huge swath of high-risk people, like those with diabetes or other forms of vascular disease.
Which brings us to a really specific and I think fascinating trial called SPARC-RCL. SPARCL.
Yes, SPARC-RCL too.
This one zeroes in on our exact topic today because they only enrolled patients who had a prior stroke, or TIA, but zero known coronary disease. No history of heart attacks at all.
Right. They randomized these patients. Half got a high dose of atorvastatin, 80 milligrams, and the other half got a placebo.
Okay.
Over roughly 5 years, the statin group had an 11.2% stroke rate, compared to 13.1% in the placebo group.
Okay, so the total number of strokes definitely went down. But here is something wild I caught in the trial breakdown.
Oh.
The SPARCL trial actually showed a modest but very real increase in hemorrhagic strokes in the statin group. Brain bleeds.
It did.
So how on earth is that considered a successful trial? Like, if the drug given to prevent one type of stroke actually causes a totally different kind of stroke.
That is a phenomenal catch, and it perfectly illustrates the complex reality of secondary prevention. You are absolutely right. The medication did slightly raise the risk of a blood vessel bursting in the brain.
So why in the world do doctors still give it?
Because of the net mathematical benefit.
Okay, explain that.
The massive reduction in ischemic strokes, the strokes caused by blockages, far outweighed that slight uptick in bleeding. You are basically trading a large risk for a small one. The total overall number of strokes still dropped significantly.
Ah, I see.
But it highlights exactly why transparency is so vital. A trial can be an overall statistical success, sure, but doctors still need to sit down with their patients and discuss the messy, nuanced reality of these competing risks.
It all comes right back to the two calculators.
Always.
You lower the cholesterol to stop the plaque in the clots, but in doing so, you slightly alter the vessel dynamics in a way that raises the bleeding risk. It's just an endless balancing act.
It really is.
Yeah.
And the tightrope gets even higher when standard statins just aren't enough.
Right.
When trying to prevent a second stroke, the target LDL, the bad cholesterol, is generally pushed below 70. But what happens when someone is already on the absolute maximum dose of a statin and the numbers are still hovering way above that target?
The baseline biology they were given by nature is just too stubborn. So what is given next? What's the next step?
Usually a drug called ezetimibe is the first add-on. It basically helps block the absorption of cholesterol in the intestine.
Okay.
But the real paradigm shift involves a newer class of drugs called PCSK9 inhibitors. These are drugs like evolocumab and alirocumab.
And the mechanism behind these is just fascinating to me. They are monoclonal antibodies. Basically, they're laboratory-made proteins that hack the liver's natural clearance system. How exactly does that work?
So normally your liver uses little receptors to pull bad cholesterol out of the blood, but there's a protein in your body called PCSK9 that naturally comes along and destroys those receptors.
Okay, so it gets rid of your liver sweepers.
Right. So what these new drugs do is hunt down and neutralize that PCSK9 protein.
So the liver gets to keep its receptors, and it basically acts like a vacuum, just sucking massive amounts of LDL out of the bloodstream.
That's a spot-on analogy, yes. And the Fourier trial tested this exact mechanism.
How big was the trial?
Massive. It enrolled over 27,000 patients. And it showed that adding these inhibitors successfully reduced myocardial infarctions, strokes, and the need for major vessel procedures like stents or bypasses.
I mean, vacuuming the blood sounds amazing.
Sure.
But, as someone learning how to read this data, I'm always looking for the catch.
Of course.
What is the downside to what these monoclonal antibodies give us?
The reality check really comes when you look at overall mortality. Yes, the Fourier trial showed fewer strokes and heart attacks, but within the time frame of the study, it actually did not show a clear mortality benefit.
Wait, meaning they prevented cardiovascular events, but they didn't necessarily prove they were extending the patient's lives overall.
Exactly. At least not in the 2 to 3 year follow-up period they studied.
Wow. Right.
Furthermore, these are relatively new agents. There is genuine uncertainty about the long-term safety and cost-effectiveness beyond those initial few years.
Right.
So while they are a powerful tool given to high-risk patients, they aren't magic bullets, and they come with a massive financial cost compared to just standard generic statins.
It's never as simple as it seems on the surface. So let's pull all of this together for you. We started by exploring how a patient's stroke is given a mechanical name in the TOAST system, from rusted atherosclerotic pipes to the debris of cardioembolism, or the crowded mystery of that undetermined bucket.
And then we navigated the mathematical algorithms given by clinicians, using SHE-OPDS2-VASC to protect the true low-risk individuals from unnecessary harm, while using HAS-BLID not as an excuse to avoid treatment, but as a roadmap to fix modifiable dangers like uncontrolled blood pressure.
And finally, we looked at the mountain of trial data progress, SHEP, Sparkle, Fourier. That proves exactly why lowering pressure by just a few points or hacking the liver's cholesterol receptors can rewrite a patient's entire future.
Yeah.
It is just a stunning architecture of logic. But before we wrap up today, what is the final thought you want to leave the listener with?
Well, we've spent this entire deep dive looking at the precise numbers, percentages, and guidelines designed to manage risk, right? The dual calculator sitting on the desk.
Yeah.
But consider this. All of these meticulously engineered algorithms are built on vast population averages, thousands of people blended into a single percentage point.
Right.
As our predictive math gets better and better, will there ever be a point where human clinical judgment is entirely replaced by the algorithm? Or will the unique, messy individual sitting in the exam room, the person who doesn't perfectly fit the average, always require a human to know when to break the rules?
Oh, wow. That is a brilliant question. The math of the masses versus the individual in the room. Well, thank you so much for joining us on this deep dive. Keep questioning the algorithms, keep seeking out the mechanisms, and as always, keep asking the right questions. We'll see you next time.